Good evening, friends. Once again, coming back to the ECG Basics 9th class. So today we'll be talking on electrolytes and heart. So basically, I'll be dealing with potassium and calcium. So how ECG changes occur, especially when the patient comes with vomiting, diarrhea, where you have potassium abnormality, and in renal failure, where you have calcium abnormality, essentially dictating the ECG and mimicking as acute coronary syndrome. We'll see what is electrolyte abnormality and how we have to diagnose it. So electrolytes are chemical substances. Chemical electrolytes are substances that become ions in solution. So that's what we call ion shifting from inside to outside cell. And this acquires the capacity to conduct electricity. This is what happens in the heart. So it's present everywhere, but I am concerned about the heart and I'll be talking about the heart. So the ions in everywhere, every part of the body control the fluid balance. For example, the sodium retains a lot of fluid. When you have sodium diuresis, it along with it takes out a lot of water. Typical SGLT inhibition action, where you have natriuresis. And this electrolyte abnormality, presence of calcium gives more strength to the muscle contraction. And this generates a lot of ATPs and energies. And this is the reason for biochemical reaction in the body. In heart, the normal state of cardiac cell membrane polarization is dependent upon the maintenance of normal ionic balance across the membranes. It's predominantly the sodium, potassium, and calcium. So this maintains the equilibrium polarization in the heart muscle. So that means that whenever it goes to the depolarization, it has to come back normal. Accordingly, the ions, electrolytes shift happens within the cell from outside. And this causes some depolarization, repolarization in the heart. So we'll see with the ECG, normal ECG, what happens, how electrolyte abnormality happens. This is the normal ECG. See here, the P wave occurs, a short PR interval, and this P to PR interval, at the beginning of the QRS complex, you have 120 to 200 millisecond, and you have a QRS which is 80 to 100 millisecond, and there is a ST segment, and there is a T wave. And following the T wave, in some places, you can see the U wave, which is almost 25% of the T wave, as the cycle upright as the T wave which is happening. So this is the normal ECG. What will happen in hyperkalemia? We'll see hyperkalemia first. So potassium is very, very vital for regulating normal electrolyte activity. Where do we give potassium in a normal situation? We give as a potassium solution for cardioplegia. That means in cardiac surgery, we inject hyperkalemia, high concentrated potassium to stop the heart. To make a surgery feasible, we stop the heart by giving potassium. This is called cardioplegia. So the increased extracellular potassium reduces myocardial excitability. So once you give cardioplegic solution, hyperkalemia, high concentration potassium, it slowly reduces the excitation and suppresses the impulse generation by the SA node, reduces conduction in the AV node, resulting in bradycardia, conduction block, and ultimately cardiac arrest. So we utilize this principle for cardiac surgery. But whether this can happen normally, yes, commonly we see it in acute renal failure, and also in after a angiotensin converter inhibitor or a ARB administration, we see a lot of hyperkalemic patients. So normal range of potassium is around 3.5 to 5. What are the characteristic ECG finding? When you take P wave is usually suppressed. So widen, then it disappears. QRS widening, because it becomes very wide, it is not contracting, it is only doing all the depolarization are acting as same. It fuses with the T wave because depolarization, everything are the same. And loss of complete ST segment, and there is ultimately nothing will be there. To begin with, actually, there will be a tall tented peak T waves. The initial part of the QRS is usually spared because the Purkinje fibers are less sensitive. So the initial part QRS complex will be spared. So generally between 5.5, no EC change occur. Between 6 and 7, there will be tall peak T wave with a narrow base. It is not acute MI, it's a narrow base, tall peak T wave. And after once it crosses 7.5, you have the P wave abnormality, QRS widening, and more than 8, you have ST and T wave, both are merged together, and QRS merges the QRS complex, and above 9, you have the sine wave pattern. Right? We'll see one by one. See the hyperkalemia, there is flattening of T wave, and gradually there will be disappearance. To begin with, the first changes will be between 5.5, 6.5, this will be the first changes, where we'll have a narrow base, tall peak tented T waves. That's the only change will be there. After that, how to differentiate between the acute coronary syndrome? Acute coronary, there is a wide base, and it is not tented. It is a rounded apex. So this will be the hyperacute T, whereas here it will be a narrow base, tall T, tented T. And you will have ST segment depression happens, widening of the QRS complex, P wave is flattened, and over a period of time disappears. And this QRS and T wave merges together, and you have a sine wave pattern. See here, peak T waves in hyperkalemia. See here, it is a narrow base, tall T, taller than the preceding R wave, tall T, peak tented T waves. Once it is there, you can see that potassium starts increasing more than 7.5, something like that. You have slowly P wave is widened, it is shortened and disappears. QRS complex is widening, it widens and slowly merges with the T wave. See here the QRS complex is merges with the T wave, P wave is widened and loss of P wave gradually, and you ultimately will have a straight line. So this is what happens in a controlled situation in a cardioplegia, where you have a bypass machine taking care of everything. But here, in a patient with a hyperkalemia, patient will die. There won't be any contraction, patient will die immediately. So you have to pick up the ECG in a hyperkalemia, tall peak T waves. That is the bottom line. So this is the T wave with which you have to pick up, and this is what the ultimate carrying a message of the stock. So we'll see that. See here, in a real world scenario, in a ECG, you are not seeing a P wave. QRS is wide, and it's always almost merging with the T wave. There is no ST segment, completely wide QRS, no P wave, and you are having a tall T, and it is almost merging together. And this is the typical of hyperkalemia, potassium around 8. If you happen to see this ECG, it means the patient is in hyperkalemia, probably acute renal failure. You have to push the potassium out of the cell and increase the contractility of the cell by giving IV calcium. And then we have to start removing the potassium by other methods like your diuresis, salbutamol nebulization will push the potassium out of the cell immediately, and your K-bind, that is a potassium resin binding solution powders can be given to excrete the potassium by way of diuretic, excrete the potassium, and soda bicarbonate to neutralize the hyperkalemia, calcium to increase the contractility and protect the cardiac muscle. So all these things it has to be given on an emergent basis. And in case of acute renal failure, we have to go for a dialysis. So this is the tall peak T wave. This potassium is around 6.5, something around that. So the tall peak T wave will be there. On correction, see this is potassium correction. The same patient's ECG. It is more than 8, around 7, normal. You see the ECG, how it is evolving. See here, QRS is widening, more widening with more potassium, and with correction, it becomes QRS narrowing, and you start appearing as the P wave, and T wave height is smaller. See here, T wave height is shorter than the R wave. See here, when it is there, hyperkalemia, there is no R wave, T wave is much taller. See here, small R wave and a tall T wave, typically narrow base. So this is a typical of hyperkalemia, how it gets corrected. When it is more than 9.4, this is what everything is merged. Sine wave pattern, where QRST, everything is merged and it is a slow, non-contracting, agonal sort of rhythm. This after this, this itself, the patient heart will not contract and you lose the patient. So hyperkalemia is a life-threatening emergency where it requires urgent attention, correction of potassium to normal very rapidly by identifying the cause. Right? So having known hyperkalemia, whether hypokalemia is easy, hypokalemia is slightly easy because it doesn't cause emergency situation so quickly. But once VTVF occurs with the hypokalemia, it is an emergency. Potassium, as I told, is vital for regulating normal electrical activity. So here, hypokalemia, predominantly the main hypokalemia reason will be not of diuretics in the administration in our practice, causes the excretion of sodium and potassium and cause hypokalemia. And also we can see during diarrhea and vomiting, patient losing potassium through some other source. So this is a common thing which we come across in practice. Low potassium results in ST depression. See, exactly opposite of hyperkalemia. Hyperkalemia is thought at all peak T waves. Here is ST depression, flattening of the T wave, negative T waves, and U wave which becomes visible. Hyperkalemia, you saw suppression of conduction system and muscle. Here, hypokalemia, atrial and ventricular rhythms are normal unless you have a VTVF. Rate and atrial and ventricular rates are within normal limit. P wave, usually normal. PR interval, usually normal, sometimes may prolong. QRS complex within the usually normal. QT interval is prolonged. It is prolonged. It ends with a U wave. Right? So you have to calculate from the beginning of the QRS complex to the end of U wave. The Q wave is QTC is very much prolonged. See here, typically P wave is present, QRS complex not very wide, and you see ST depression, and you have a positive U wave. See here, the QTC is prolonged. Roughly, you can see more than 60-70% of the between the RR interval means it is very much prolonged. U wave is present. So QT interval is prolonged, U wave is prominent, and you have ST depression, typical of hypokalemia. See here, normal looking P waves, slightly prolonged PR interval may be there, QRS complex may be normal, and you have a ST depression followed by a positive final U wave, and this is the U wave QT prolongation, typical of hypokalemia. See the basic ECG, it is completely prolonged, and you have a U wave, which is upright and prominent. You can see this here. It is a QT prolongation, QU prolongation rather, and you can have a prominent U wave, ST depression with tall upright U wave, which is become prominent because of the ST depression. Typical of hypokalemia, see here ST depression, upright U wave, QT prolongation. The other waves are near normal. You can see the P wave, QRS complex is normal. So this is a typical of, it is not ischemia. Here it is not ischemia. There is no symmetrical T wave. It is not ischemia. It is a ST depression with a upright U wave. It is hypokalemia. Typical of hypokalemia, numerous ECGs I am showing. See ST depression, U wave upright, and you are having QT prolongation. Your P wave is normal, QRS complex normal. Simple. It's a hypokalemia. So hypokalemia, hypokalemia, you are having ST depression, upright T wave. See here, U wave. Here, whereas in hyperkalemia, exactly opposite, you are having tall peak T wave. See here, tall peak T wave. QT may be, QRS may be widened, and you are having P wave may widen or disappearance of P wave with increasing potassium. And this is what is hypokalemia and hyperkalemia is. So moving from the hypo to hyperkalemia, now you go to the next electrolyte, hypercalcemia. So hypercalcemia is not frequently you come across. People with hyperparathyroidism and all these conditions you can come across, or congenital conditions will be there. But usually, general practice, we don't come across. What is the abnormality? See here, in the depolarization, in the phase 2 of the phase, you have the calcium exchange. It is almost sort of between sodium and potassium. It is acting as a balance and sustaining the phase between depolarization and repolarization. So this is what, so between means it is predominantly acting on the ST segment. So hypercalcemia, hypocalcemia, when there is more calcium, ST segment is very much active. So it means it becomes very narrow and there is shortened QT interval. So whenever you have a shortened QT interval, you have to see whether there is hypercalcemia. See here, everything is normal. Atrial ventricular rhythm will be regular. Rate will be near normal. P wave normal size. PR interval may be prolonged. QRS within normal limit. QT interval, ST segment will be shortened. ST segment will be shortened. Right? See here, normal patient. This will be the QRS, P wave, QRS, and ST segment and U wave. There is a smooth transition between these two. See here, in the case of hypercalcemia, almost there is no ST segment, and this resulting in a short QT interval. So whenever you see a short QT interval, you have to see any endocrine abnormalities causing hypercalcemia, right? So this, in a after a malignancy, a patient on treatment with malignancy, you can always find this type of ECG where you have a malignant lysis syndrome can cause this type of features. See here, there is a short QT. Short QT, the ST segment is very, very short. Very, very short. You saw in hypokalemia, it was very wide. Now you are having a short QT and typical of hypercalcemia. So you come across very rarely. It is not. It is usually, it comes in with the endocrinologist where you commonly see this type of ECG. And they refer to us for this short QT. The next abnormality is hypocalcemia. So hypocalcemia, predominantly, this happens in renal failure where kidney is the one which produces, helps in the production of calcium along with the sunlight and the skin. So this vitamin D metabolism will be helpful with the renal function. In absence of in the renal function, renal failure, you got decreased less calcium. So in decreased calcium, exactly that it is almost acting on the ST segment. I told you calcium belongs to the ST segment. So it means that rhythm and rate will be normal, P wave will be normal, PR interval will be normal. QT interval will be prolonged, predominantly the ST segment prolongation. Hypocalcemia also, ST segment depression happens, whereas here you will not have depression, but you will have ST segment QT interval with the prolongation of the ST segment. See here the normal QT, it is stopping here, whereas the ST segment is prolonged in hypocalcemia and QT interval is prolonged. See here the typical ECG, acute renal failure, ST segment is prolonged, tall peak T wave of potassium, hyperkalemia. See here, it's a typical ECG of renal failure, hypocalcemia, ST segment is prolonged, and tall peak T waves, renal failure. So hypercalcemia normal, you have ST segment, smooth transition into T wave. Hypercalcemia, ST segment is shortened, so short QT interval, whereas in hypocalcemia, you have ST segment prolongation and QT interval is prolonged. Simple. So to summarize what I told, hypokalemia, ST segment is depressed. This is a summary of it. Please understand. ST segment is depressed and you have a upright U wave. This causes QT prolongation. So QU actually prolongation. So flat, this is a depressed flat or inverted T wave followed by a upright U wave. Hyperkalemia, You have first to begin with tall tented peak T waves, and then you are having a P wave is flattened, disappears, QRS is widened, loss of ST segment, QRS and ST segment summates, you call sine wave pattern, and this is a real emergency to treat with. Hypocalcemia, renal failure, prolonged ST segment causes hypocalcemia, and this resulting in prolonged QT interval. Hypercalcemia, there is loss of the ST segment because the calcium is high and it rapidly acts. So this causes shortened QT interval. So you are having long QT hypocalcemia, long QT hypokalemia, shortened QT hypercalcemia, and narrow, tall, tented peak we get T waves, you have hyperkalemia. Now with this ECG findings, you can easily make a diagnosis of electrolyte abnormality in ECG. Predominantly, the history helps you out. Patient will be in renal failure or in diuretic or in acute renal failure, either hypocalcemia or hyperkalemia. In case of diuretic impaired, you have hyponatremia, hypokalemia, and in case of hypercalcemia, usually the endocrine abnormality, malignant lysis syndrome, or hyperparathyroidism can cause these features. And most of the time, you will find electrolyte abnormalities in this background of ECG, and it is easy to diagnose with the short ST segment and T wave. You can always QT interval, you can always diagnose most of the electrolyte abnormality, and hyperkalemia is the most dangerous of all. And hypocalcemia is also dangerous when it leads to VT and VF. Thanks for your patient hearing. I will stop with this. I'll unmute everybody.